I'm so excited to be able to present our experience building a multidisciplinary juvenile myositis clinic at the University of Michigan over the past 3 years. And when I thought about starting to make this talk, I really did reach out to everyone who is an integral part of our clinic because I really could never do this alone, and I don't have the expertise to do all that we're able to do now in our clinic. And so I'm just really grateful to how we've been able to develop a team here. And I also hope this is a forum to really start discussion of how we're running our clinics and how we can learn from one another at different centers in the clinical care network. There's great models in the centers of excellence through CareJam, and so I know I can learn so much. And so I want to emphasize this is a single center experience, and we're pretty new to this, and so we have a lot to learn from all of you. And I also want to just say that it's only through patient and family experience that we've really been able to develop this clinic. And a patient and family advisory council is really integral to starting this clinic and beginning this effort. So just to lay out the talk, so I'll first really start by just discussing the benefits of multidisciplinary care for JM patients and families that we've seen in practice. I'll then really talk about our experience and how we approach care for our JM patients in our clinic at Michigan. And then I do want to speak a little bit to just how it's much easier to integrate translational research in the setting of a multidisciplinary JM clinic. And ultimately, I really do believe that this research will change outcomes for patients and lead to faster advances in care by being able to have this model of kind of integrating with the JM clinic. And I'll speak a little bit more to kind of future developments that we hope to integrate into the clinic that are not ongoing right now. So just to speak a little bit, and I would love to discuss this topic more with other people in other centers as well too, but as we all recognize, each patient has individualized care needs and can really benefit from additional time and assessment to really determine root causes that are impacting care and different challenges. And so the benefit of a team-based multidisciplinary approach is that we can address all needs of patients and families, and we have the time to do it, including psychosocial needs. We're also able to gather perspectives from team members with different expertise, different training backgrounds to finalize on a best care plan for a patient. As we all know, sometimes there are gray areas and there's not necessarily one path forward to pursue for treatment or therapy for a patient. I also think it's so important to integrate patient and family experience to guide continued clinic changes to improve patient experience. And we're additionally, again, able to integrate the opportunity to participate in research within our clinic flow to generate a JM registry and biobank and fast track search for patients and families. So within our clinic, some of the specific kind of care needs that we've been able to identify through this integrated clinic setting, we've been able to have the time, again, and the rapport with patients and families to really identify kind of deeper underlying root causes of challenges in care, such as difficulty accessing care, getting to infusions, medication adherence, that really, some of these troubles haven't come out until a couple visits or more time in the clinic setting. Also, coping with a chronic illness. We also have found that with having dermatology in clinic, we've had improved diagnostic capacity and ability to sometimes differentiate non-JM patients for being initially evaluated in our clinic and get them to the right providers. Also with dermatology, we have a more comprehensive approach to treating persistent skin disease and calcinosis. We have the opportunity to do intralesional injections and a broader bandwidth for topical therapies. I think it's also very important that we have PT and psychology integrated within the clinic. So we have continued follow-up plans within the multidisciplinary JM clinic, as well as an outpatient follow-up plan for these patients that's already in place. And then other things such as advocating for school accommodations. We have a social worker in our clinic as well, which is really helpful. So in terms of our clinic model, and this is constantly evolving. When I started as faculty, we didn't have a JM clinic, and I realized, when I was on call, I had a number of new JM diagnoses, and we've had a pretty large cohort for a single center. So we decided to build a juvenile myositis clinic to expand access to care and provide excellence in multidisciplinary care. We reached out to ask for involvement of a pediatric physical therapist to start. So we really started with physical therapy and pediatric rheumatology. We actually have now 5 pediatric rheumatology providers in the clinic. So a unique model we also have is that we really want all of us to be caring for JM patients. And also we just have everyone interested in caring for JM patients and really wanting to be able to provide a good assessment and use standardized measures. And so we also have dermatology. Dermatology is quarterly right now, but we're hoping to increase frequency of dermatology in clinic. We have psychology every clinic now, as well as social work. We have a really close connection with a neuromuscular specialist too, who also helps us in patient assessments as well. And she refers patients to me, and we refer patients to one another as well. I think also, patient-centered care is so important. So as I mentioned, I'll talk a little bit more in the next few slides, but we have a patient family advisory council. We meet quarterly, and it's been just incredible to get feedback from patients and families on how to guide changes in our clinic. And then in terms of excellence in clinical care, too, we've started implementing Nailfold Capillaroscopy over the last year, and that's been really helpful for patients and families to feel more connected to what's going on with their disease. They've really mentioned that as a visual tool. That's been something very impactful. Another huge component is education and mentorship. So we're able to provide training and standardized measures and JM patient assessment to trainees rotating through the clinic, to our peds rheumatology fellows, to other junior faculty. And so that's been really wonderful to have that, for them to be able to see that many JM patients in one day, or if they're only in our clinic for a week. That's been wonderful. And we do not have a dashboard. I would love to do something like that. So that's amazing. We do have standardized note templates for new and follow-up patients. And so that's been really helpful to collect standardized data in all patients that can be used by all providers. And we are starting to use flow sheets, but we really just use them for muscle measures at this time. So just to emphasize, I'd love to hear what other centers are doing in terms of patient engagement, but we have the JM Patient Family Advisory Council, and Office of Patient Experience at Michigan is really amazing and helping to recruit and train PFAC patients and family members. So there's about 30 PFACs at Michigan, and so we meet quarterly and can share and brainstorm ideas to help other groups in terms of recruiting new members, increasing diversity in our PFACs, implementing new projects, and how to come up with some challenges too in terms of getting more participants at meetings and things like that. So we currently have about 12 patient and family JM PFAC members. But we have really wonderful meetings, and I feel like I just learned so much from these meetings. So this has been amazing. Some of the goals that we have at our PFAC, so engaging patients and families really in the key needs to improve care, to improve patient experience, also to improve quality and safety of care, really having a patient-centered approach to care overall. And then another piece is determining key research priorities. What are meaningful research priorities for patients and families? What do they hope that we can pursue as the next research project, and involving them in all stages of the research project. And then also designing educational resources that are, lacking or not sufficient for patients and families right now. We hope to partner with the community more in the future. Our PFAC at Michigan, we've had a number of great outcomes. We advocated through this group for a pediatric psychologist to join our clinic. I had been speaking to the division of pediatric psychology for about a year before we actually got a pediatric psychologist in our clinic. We have developed 2 educational handouts for patients and families, one on signs and symptoms of JM flare and one on JM and exercise, which I'll show on the next slide. And I'm happy to share these with any other centers as well. We've submitted a grant application for a JM Patient and Family Day with the input and guidance of patients and families. We've integrated use of Nailfold Capillaroscopy. We've identified community champions for research projects, and we're now training peer mentors for a new peer mentor program. I won't show this in detail, but I know our patients and families, we're really proud of these handouts we've made, and our patients and families really, from every step of the way, reviewed all the content, helped with the image development, and so we're very excited about these. And now to speak to individual people and their roles in our clinic. So Kara Commissar, with her picture there on the right, is the physical therapist in our JM clinic. So she's been in our clinic since our first JM clinic in August of 2020. She performs initial PT evaluations, provides recommendations for outpatient therapies, assists in guiding patients in return to exercise and strength training, advice on recreational activities, as well as energy conservation ideas. Importantly, she's really the connection. She is a PT supervisor at Michigan, and so she does educational outreach to therapists outside of our JM clinic and help, if they're seeing some of our JM patients, she will help provide training to them as well, and education to them. So that's been wonderful. She also has started to do more education just about JM within her department. So initial assessment, so Kara assesses joint range of motion, flexibility, balance, functional mobility, gait, so standard things she would do in a PT evaluation. But she is also helping to collect all of her manual muscle testing and CMAS scores, as well as doing a 6-minute walk test in patients. She is using flow sheets to input these scores, which is wonderful. So in a busy clinic, it's just wonderful to have her being able to help with these assessments. At follow-up visits, we do standardized testing at each follow-up visit for all patients. But she also provides recommendations for continued need for outpatient therapies and frequency and return to sport and exercise. And I just wanted to highlight with all of these specialists just a few patient cases. And I actually asked our physical therapist and psychologist to provide a case that they felt kind of showed how this multidisciplinary care has been impactful for some patients and families. So we had a 7-year-old little girl who had been diagnosed with JM about 5 months prior to this visit. And on exam standardized testing, she had really good muscle strength, but she came to clinic in a wheelchair, and she was still using a wheelchair. And so we were all kind of independently assessing her and trying to, discern why that might be. And it turns out that, she actually had a lot of anxiety and fear about not using the wheelchair after she had been using it for much time before she came to her initial visit with us. And so it was really only after she met with our physical therapist and our psychologist and was able to kind of discuss these fears and concerns and receive assurance and confidence that it was okay to independently ambulate and come up with a very specific plan about how to start that process and get back to dance, which is what she loved to do. And this was just incredible to see her the next visit in terms of her being back to dance and everything she was doing at that point. So I think this really demonstrates, having multiple providers, having rapport with the patient, how this really changed outcomes for this. In terms of psychology in clinic, Dr. Luke Turnier is the psychologist in our clinic, and we hope to get another psychologist as well. So since having our psychologist in clinic, we've been able to integrate a mental health screening measure for all patients, provide assessment and treatment of mental and behavioral health concerns. We're able to better understand how psychosocial stressors may be impacting care, treatment, and quality of life. And we're also better assessing for symptoms of fatigue, pain, change in mood, anxiety, and sleep. I listed here some specific ways that a psychologist can be helpful in JM clinic that Dr. Turnier had written, but they're many, including coping with a chronic illness, but also behavioral concerns at home or school, helping families to accommodate or advocate for school accommodations, addressing mood and anxiety concerns, helping with adherence to the medical treatment plan, as well as needle phobia. So this is kind of our model right now from first visit to follow-up. So the first visit really is to establish rapport with the mental health provider and really giving all patients an opportunity to meet with our pediatric psychologist. There's assessment of psychosocial functioning via standardized questionnaires and an intake interview. And it addresses not only psychosocial issues potentially related to the recent diagnosis, but also things not related to the diagnosis, whether it be sleep, executive functioning difficulties, toileting, so a lot of other things, similar with dermatology, where there's other non-JM rashes that we can also address that will also improve quality of life for our patients. So 2 models for follow-up. So the same mental health provider is able to see patients for regular follow-up in our JM clinic and standardly look at the standardized measures we have, as well as medication adherence. We also have a more frequent follow-up within a virtual outpatient continuity clinic that we've created. And so this is virtual, so it can really be accessed by our patients who live far away in Michigan, which has been really wonderful. And I just wanted to show, again, one example of a patient case where we really identified underlying behavioral health needs that were impacting care and quality of life. And so we had a 12-year-old girl who had been diagnosed with JM about 2 years ago. This was her first appointment in the multidisciplinary clinic. And the Promise 25 standardized measure, as well as the clinical interview, really showed us that there were significant concerns related to mood, as well as social functioning. And so she's now getting regular virtual follow-up in the outpatient continuity clinic with Dr. Turnier. And there are plans in place to really address not only medication adherence and increasing positive interactions with caregiver, but also coping strategies for acute anxiety and needle phobia. And so this has really been improving her overall quality of life. Our dermatologist in clinic is Dr. Mancuso. So Dr. Mancuso has been instrumental in opening avenues for further topical non-systemic treatments in our clinic. The wonderful part is she can provide expert clinical assessment and treatment recommendations for skin rashes, not only JAM specific, but other common rashes as well. She's also able to perform biopsies in clinic if needed diagnostically or to direct care. And she can also perform intralesional injections in clinic and recommend topical treatments. And it's also very interesting to discuss with kind of dermatology and peds dermatology. Sometimes I think we do have differing opinions on, how aggressively to treat, skin rash or skin inflammation. And so that's been really instrumental to have those discussions with our dermatology colleagues. It's also wonderful at guiding on optimizing sun protective measures and providing very specific recommendations for best sunscreens and brands of sun protective clothing. And one other piece I just want to highlight before I kind of end this clinical care piece of the talk is that we have been starting to use Nailfold video capillaroscopy. This provides non-invasive exam and analysis of microcirculation changes, and it really has helped to aid in diagnosis in some less skin predominant patients that we've seen recently, which I'll show in the next slide. It really provides a great visual aid for discussion with patients and families. We're also able to have the feature of directly comparing images from the same finger, one visit to the next, to really look at how the morphology of a capillary has changed or the size of a capillary has changed. That's been wonderful. We're looking into creating reports similar to PFT reports for Nailfold Capillaroscopy right now. And so in this patient's case, I really do feel like Nailfold Capillaroscopy helped aid in diagnosis and certainty of diagnosis more than anything. This was a 4-year-old little boy who was initially given a diagnosis of probable muscular dystrophy. He was seen in our muscular clinic. Genetic testing was negative, so he was evaluated in our multidisciplinary JAM clinic. He was found to have a faint heliotrope rash, but definite Nailfold Capillaroscopy changes, if you can see in label B down here, but you can see definite disorganization of Nailfold capillaries, decreased density, dilation. And so this was his treatment naive. And then 4 months on treatment, you can really see that there's improved density of the capillaries, no further dilation of the capillaries. You can see more normal hairpin loop morphology. This child was ultimately diagnosed with NXP2 positive JDM and had muscle biopsy as well that confirmed this. I think I'm running a little long, so sorry. I just wanted to highlight very quickly that having a JAM clinic has also really streamlined our ability to integrate clinical data with research and develop a JAM registry and biobank to accelerate research. So I'm going to highlight some of the ongoing research focuses at our center just very quickly. So we have a focus on the study of skin disease really to better understand disease heterogeneity and develop novel biomarkers and treatment targets. And in particular, we've been leveraging something called tape stripping, which is non-invasive, to look at transcriptomic signatures in skin to really understand treatment response and hopefully develop diagnostic and treatment response signatures. So more to come on that soon. We've also had a focus on comparing to childhood onset lupus to really understand what's specific about JM that leads to the clinical manifestations we see in JM and the organ-specific tropism in JM being more localized to muscle. And one of the newer focuses we have is pairing the Nailfold Capillaroscopy data that we get with endothelial cell functional assays to really understand how are these Nailfold changes connected to systemic disease and how can we potentially use this Nailfold data to guide clinical care. And then I just wanted to mention as well that we're very excited that we've been able to launch 2 multi-center research initiatives over the past 2 years. And I really do feel like teamwork is key to advancing care for JM patients and families, both clinically and in the research field as well. So we are completely open to collaborate, and I would love to collaborate more with other centers. And I just want to emphasize that none of this work would be possible without all of the collaborators and all the other PIs on these grants. But just one slide on each. But as Dr. Heaton mentioned, we have a new project, single cell ALIS, to accelerate precision medicine and JDM. We're very excited to partner with the community, patients and families, Cure JM, many other centers, including Duke, Lurie, UCSF, and University College of London, to really develop this first cross-tissue spatially resolved atlas that will hopefully allow us to understand more about the causes of JM. And then one other major project we're involved in, we have a care large to really look at treatment response at a molecular level in JM patients. And we're digging through this data right now and trying to see what we can understand about how treatment responders and non-responders differ. But very interestingly, we have about 50 patients with treatment naive samples. So on the left column here, this is log fold change, but we have a treatment naive visit and then 6-month follow-up visit. And essentially what we saw just from this initial heat map is just that, interestingly, there's still dysregulation of cell death processes, DNA repair processes, and metabolism, even at 6 months. So there's a lot of potential future candidate biomarkers. And I won't spend too much time on this, but we have a lot of other thoughts about how to kind of further develop the clinic. And we always, again, look to our patient and family advisory committee meetings to kind of discuss a lot of these ideas. But we hope to expand multidisciplinary care even further. A huge next focus is also community outreach at local clinics and hospitals to really raise awareness for JM diagnosis and care. We'd love to have an outreach site further north in Michigan. Patient engagement efforts, we're developing a photo protection handout right now. We also would love to be more involved in education and mentorship and multi-center research. We'd love to do a clinical Nailfold Capillaroscopy study across clinical care network programs. Partnering with Adult Room at UM, we have a wonderful adult room program here, and we're hoping to get an adult DM cohort started and look more at transition. And then we'd love to get access to more photoprotective clothing, sunscreen activity trackers for our patients as well too. And I just wanted to say, thank you to our whole team. I could never do this alone. And thank you so much to our patients and families that are part of our PFAC. We couldn't have ever done it without them. Thank you, everyone. And I would love to learn from all of you more.
Thank you, Jessica, for a wonderful introduction to your amazing clinic and what you and your team have accomplished. I know there are some questions coming up on the chat. As those appear, I might just kick it off with, how important has it been to your research to actually get access to samples from things like the Lurie biorepository and the CARA biorepository?
Yeah, I mean, I think it's been critical. I would say that, when I came here, we didn't have any patient samples. We didn't have a clinic. And so to get started in asking research questions, I worked with, Dr. Pockman at Lurie to get started. And then, again, it's really hard to find treatment-naive samples and to find an inception cohort, as been mentioned. And so, that's really, I think it's going to be critical to develop the further research questions that we can answer as we develop these biobanks at our clinical care network. So it's been an amazing resource. Yeah. I'm just looking through everyone's questions, but please feel free to ask. I did from Susan. I can definitely share the handouts. I would love to kind of combine efforts and have a meeting to discuss kind of what we're all doing and what resources we do have at our independent centers to really merge everything together. CareJam has resources. We all have independent resources, but seeing what we all have, and so we can, focus on putting that together. Belina has some questions. How often do you have JM clinic? Ours is currently just once a month for a full day, so it's not as frequent as some of the other centers of excellence. I would love to have it more frequently. The visits are pretty long. We actually have hour-long time slots as PEDS room with the patient, and then PT and psych each have 30-minute time slots with the patients. And our social worker kind of goes in when's a good time. Same with our clinical research coordinators. There's usually some time in between. We kind of have a system to flag who's in there, who needs to go in right up front when the patient gets there. We take the off when they've gone in, and then we all discuss together. I usually have the trainee, the physical therapist, and there's usually a dermatology trainee as well, as a PEDS room trainee, and the physical therapist all go in. So I have all that information before we go in ultimately as well. PT is there every clinic visit, as well as psychology. Dermatology right now is just quarterly. So we try to focus the clinics where dermatology is there to have the skin predominant patients or the patients with resistant skin disease at those times. But we're probably, there's more PEDS derm. We had one PEDS derm, and just recently in the past few months, we have 2 more. And so I'm hoping to get an every other month dermatology presence. I'd love to hear more about how you got connected with a physical therapist and convinced her to join JDM clinics. There seems to be a disconnect between PT and rheumatology at some centers. And I would say, I feel like it took some effort to get both PT and psychology in the clinic. So I initially reached out to the PT supervisor, division director, and really said, this is why we want a PT, this is why we need a PT. And I ultimately started funding partial effort, from my startup for the PT to start. just to kind of get people invested. And now she's like super excited because it's nice for them to have a focus area to really learn more and get closer to a group of patients where she didn't have that before. And now she's a supervisor and she really does like JM clinic and outreach. So it's just become something now that she loves and she wants to be involved in research. What do you do regarding transition to adult care? That's a great question. It's something that I would say is not well developed at our center yet. But we do have actually 3 med peds rheumatologists at our site now, and they've all been recently graduated fellows. And so we have one in particular that works and has some research effort with me, Dr. Jackie Madison. And so she's very interested in developing a transition program for our JM patients. And I'm also pretty connected to adult room just with research efforts as well. And so we're hoping to develop that more formally. But right now, I would say there's really not a formal transition program. It's really, I think that we're very connected to adult room here because of our med peds colleagues. And so I reach out to them and I say, I discuss, the patient, we find the best fit for that patient. But I'd love to have like a joint clinic visit between like peds and adult provider before that process happens. Avia says, do you have any recommendations of how to make this process of establishing COEs more accessible to a wider array of pediatric rheumatology sites as well? Yeah, no, that's a great question. I was thinking about this as a pain to talk together because this is certainly hard to get all these specialists together. There's unique challenges at each site, I would say. And so I think it is really challenging. I feel like it'd be good to have probably one-on-one or group conversations to discuss unique challenges and strategies to overcome those too.